Good morning, everybody. I don't mean to begin this presentation with a disparaging remark, but it is interesting that the two attorneys that presented quickly ran out after they gave their presentation. If my voice holds out, I will spend a few minutes talking to you or reacquainting you with the Medical Quality Assurance Commission and our role in the process, and then Dr. Patterson will walk you through, since she was our leader in the process and working with the other boards and commissions in putting this rule together. She will go over those other points. First, what is the purpose of the commission? What are we all about? By law, your commission is given the responsibility of licensing physicians, of enforcing qualifications for licensing, consistent standards, continued competency and discipline, and we are charged also with developing rules and policies and procedures that relate to improving quality of health care for the citizens of our state. What this statement implies but doesn't really talk to is the educational role that the Commission has taken on in order to accomplish its mission. So in addition to policy and rulemaking and licensing and discipline, we are spending more and more time getting out and about educating providers about what we do and how to practice medicine in accordance with our medical regulations in our state. We have 27,000 licensees in our state. We license not only physicians, but physician assistants who work with allopathic physicians. Of that 27,000, by the way, about 6,000 are licensed here, but probably do not practice in our state. We are a semi-independent group. We are appointed by the governor. We serve for a 4-year term with the possibility of a second 4-year term. We're 21 members, of which 13 are physicians, at least one from each congressional district. We have 2 physician assistants on the commission and 6 public members. And in the past couple of years, we have added several pro tem members that help us do our work. That is our staff. We have about 35 total people, including investigators and attorneys and administrative folks that do our work. We are by law required to be self-supporting, and we do that by having each of us pay a licensing fee. This slide is the last 2-year budget cycle. The current budget cycle is basically the same. One of our responsibilities is to discipline when appropriate, and in order to do that, we use a law which is the Uniform Disciplinary Act, and there are basically 2 categories of violations, as you can see there. One, unprofessional conduct, and the other, impairment. The impairment involves perhaps 5% of the work that we do. The majority relate to clinical competence and other violations of that act. Give you an idea about how much work we do, and our work is growing as a commission. In one fiscal year, a 12-month period, we looked at about 1,400 reports that come to the commission, either complaints by colleagues, pharmacists, patients, family members, from law enforcement, from L&I and other state agencies. We get reports from many sources. We hear those cases briefly and make a determination. A group of the commission makes a determination whether or not a case should be opened at that point. We are very conservative in the sense of trying to protect the quality of the physician as well as taking care of looking after the patient. So we feel opening a case and making sure everything is the way it's supposed to be is in our best interest and in your best interest. And so we open about 3/4 of the cases we hear, which is different than most of the other boards and commissions. And as you can see, in the course of a year, starting with a number of 1,400, we wound up doing about 92 disciplinary actions of those kind. And unfortunately, in this slide, which is busy, it doesn't really specify cases that are related to opioid use. I would tell you that we meet every 6 weeks as a commission, and there are several cases relating to opioids at every one of our meetings. And in the overwhelming number of cases, the care provided is appropriate, but there still continues to be an issue. As you can see on this slide, the majority of the cases where we wind up doing discipline relate to clinical issues. There are indeed other issues that relate to boundary issues and fraud and that kind of thing, but overwhelmingly the cases relate to this 77 and the out-of-town actions, out-of-state actions rather. Other states, we require, if another state takes an action on a licensee and that individual is licensed in our state, we take a similar action. So again, as you can see, of the total number of cases, overwhelmingly, they are clinically related. And now I'll pass this on to Dr. Patterson.
Okay, thank you. Thank you, Les, and my good morning to you, and thank you for being here. And don't you feel better already, knowing what the state is doing about the problems from the data that you heard this morning? So I'm here now to talk about the content of the rules, and I'm actually going to just skip through these slides. You've heard all of that. But I would first like to talk a little bit about the process. Mike Tribble talked to you about how we, as the Medical Commission, met with 4 other boards and commissions, and we all had to come to some consensus. And that was an interesting experience. I will tell you, the Medical Commission really led the way in terms of writing the rules. So we get the credit or the blame, depending on who's talking. But it really has been an experience. And to take such a clinical matter and to put it into rules, i.e. law, into legal language was real challenging. We would come up with what we thought should be done, and then it would go into this black box in Olympia and come out in legal language that then we had to interpret. So it really was an experience in learning. I would also comment that the last rules we did were office-based surgery rules, and they took us 8 years. And we had our first meeting of the big work group just exactly a year ago today. So this was done in a very compressed time frame. So I will now talk about the rules for the treatment of chronic non-cancer pain. The legislation required certain elements be put in the rules, and those elements include a dosing criteria, guidance on seeking consultations, guidance on tracking progress, and guidance on tracking the use of opioids, which is going to be much easier to do now with our prescription monitoring program. And it's my understanding that that program will go live in January of this year, at the same time that the rules need to be implemented. So although the legislation required just certain elements go into the rules, we felt like a very comprehensive rule of a standard of care for pain management should be written, and that's what we embarked upon. And we spent a great deal of time reviewing multiple state guidelines. No other state has a rule. We're the first to do that. But many states have guidelines, and there are Canadian guidelines that are incredibly comprehensive about the use of opioids for chronic non-cancer pain. And we literally spent hours reviewing all of this information before we even had our first meetings. So the elements of the rule that we have come up with include a preamble, exclusions, certain definitions, patient evaluation, treatment, informed consent, periodic review. We address CME and the consultation requirement and how you get out of the consultation requirement. And then the most difficult of all was the definition of a pain management specialist. So we did all of this in the context of our mission in the commission, and that is to protect the public. And when you think about protecting the public, we're not only thinking about protecting the public from opioid bad prescribing, but also protecting the public's access to pain care. And the two could seem like opposing interests at times. So to begin with, the preamble, and the preamble was fashioned after the Federation of State Medical Boards model policy, as was the entire rule. And the preamble discusses the overall approach to pain management. I would encourage all of you to read that. It basically talks about the multidisciplinary approach that needs to be done for pain management. And it also talks about that each patient is individual, and ultimately it's the physician's judgment in terms of what needs to be done. What we ask at the commission is that whether you follow the rules or you make an exception to the rules, is that you document, document, document. Because for some reason, should we be looking at your care, all we have are the medical records. And so what is in there is what we base our decisions on about possible disciplinary action. Now, one of the questions you may have about these rules are, is the medical commission going to be monitoring what I do? And the answer to that is no. The only time the medical commission is going to be reviewing your work is if you have a complaint filed against you, and we do an investigation, and then we review the work. So nobody's going to be out there looking. If you're the member of a large organization, for example, Swedish, they are going to be looking because it's a quality initiative. So there are some groups out there that are going to be monitoring the standard of care, but the commission is not going to be doing that. Again, the intent of the rules was to govern the use of opioids in the treatment of patients with chronic non-cancer pain and to assist practitioners in providing appropriate medical care for individual patients. The exceptions to the rule that you've heard are hospice care and palliative care. And as you know, palliative care is appropriate for anyone with any symptoms at any age and any diagnosis. So the definition of palliative care is broad. For the purpose of the rules, we have defined palliative care as care being given to those persons with a life-limiting illness, probably a life expectancy of a year or less. So hospice care, palliative care in the face of a life-limiting illness, or other end-of-life care are all exceptions to the rule. So let's start with patient evaluation. The rules contained the word shall and should, and I ask you to pay attention to that. So the physician shall, that is, must, obtain, evaluate, and document in the health record current and past pain treatment, comorbidities, and any history of substance abuse, either history of or current substance abuse. And obviously, from what the data you've heard today, how important that is. The patient evaluation should, that means you aspire to, include the review of any available prescription monitoring program and relevant information that may be provided by a pharmacist. Some physicians are concerned that this prescription monitoring program now is going to take extra time, but it is not the physician who enters the data, it's the pharmacist. Your obligation is going to be to have access to that database and to review it. So the patient evaluation shall, again must, include a physical exam, a description of the pain, the effect of pain on function, all medications being taken, and a risk screening tool. Now he's walking out on me. The treatment plan shall state the specific objectives to be used to determine success of the treatment and must include functional assessment. You know that assessing chronic pain is much more than getting a pain score, and that can be very misleading if you're only listening to a pain score. And so it must include functional assessment. And we've been challenged by this because when people think of functional assessments, I think they think of evaluations like an independent medical exam. And your functional assessment should be very specific to the patient's life and lifestyle. Maybe as easy as the goal is, I want to be able to go grocery shopping. I want to be able to unload my dishwasher. I want to be able to lift my grandchildren. So in terms of functional assessment, what does the patient want to be able to do as a result of your treatment? So it doesn't have to be an overwhelming functional assessment, but what are the goals that the patient has? We want to see that in the record. Informed consent, the physician shall discuss the risks and benefits of all the treatment options. What about a written agreement? The written agreement should include the fact that the patient should receive prescriptions from one physician and one pharmacy. If the patient is deemed to be at high risk by the risk screening tool that you are required to evaluate, then you have to use a written agreement, and that includes 10 different elements that are described in the rule. Well, what about required CME? Well, there's a couple of ways that CME come into the rule. The first is that physicians prescribing long-acting opioids should, so this is a should, it's not a shall, have a one-time completion of at least 4 hours of CME relating to the topic of the use of long-acting opioids. So this is a once-in-a-lifetime 4-hour CME, okay? What about episodic care? Anytime a patient comes in for episodic care, i.e. in an urgent care or in the emergency department, you should review information that's available through the prescription monitoring program that we'll now have as of January. You should avoid prescribing opioids for chronic care in the episodic care setting. The prescriptions shall include the indication, that is the ICD-9 code, and require photo ID to pick up. Now, if the patient isn't picking up the medicine, whoever picks up the prescription has to show a photo ID. And then this information is to be relayed to the primary prescriber. What about consultations? We're very concerned about consultations because of the limited number of pain specialists in the state. The rules state that you shall consider referring as necessary, particularly those high-risk patients and patients with multiple comorbidities. We do have a trigger dose that requires a consultation. That doesn't mean you have to get to that dose before you should have a consultation. You can get there at 10 or 20 milligrams if the patient is having problems. Mandatory consultations are required for patients who are receiving 120 milligrams of morphine equivalent dose. And there are ways to convert other opioids to morphine equivalent dose. And on the medical director guidelines, there's actually a calculator that will do that for you. So if you are prescribing and your patient gets to 120 or above, then you must seek a mandatory consultation unless there are special circumstances or you're an exempt provider. Now, this 120 milligram trigger dose, if you will, was intended to do a lot more than require a consultation. It was intended to make the physician think, wow, I'm getting into dangerous territory. You saw the data today. Risk is dose dependent. So not only does this dose require a consultation, but it also requires careful thought. Do I want to continue with this or do I want to go higher? So the mandatory consultation is required unless there's an exemption. There are special circumstances or you're an exempt practitioner. And I'm going to talk a little bit about that. The mandatory consultation shall consist of one of the following: either an office visit with a pain specialist, a telephone consult, or some type of electronic consult. We think those are going to be hard to come by. They're time consuming, it's expensive, and there's not going to be a lot of physicians out there willing just to take your phone call. But if indeed you are fortunate enough to have a telephone consult, then that needs to be documented in your medical record. Another way a mandatory consultation can occur is with audio-visual evaluation by a pain specialist. With telemedicine, with Skype, there are going to be more and more ways to have patients with access to a pain specialist. So what are the exigent or special circumstances when no consultation is required? Well, if the patient is on a tapering schedule, a lot of physicians are concerned about obviously the numbers of patients that show up in their office that are already taking large doses of opioids. But if the patient is on a tapering dose, then you do not, and the patient is taking 150 milligrams of morphine equivalent dose a day, you do not need to seek a consultation if they are on a tapering schedule. If the patient is having acute pain and the dose is expected to return to or below baseline, you've documented reasonable attempts to refer to a specialist. And this is going to be a challenge in some of our rural areas. And it's an insurance challenge, because many patients that don't have insurance cannot get in to see a specialist. So if you've done everything you can to seek a consultation, yet there are barriers to that consultation, your obligation is to document, document, document. And I hope that's clear. And another circumstance under which a mandatory consultation is not required is if physician documents that pain and function are stable and the dose is stable. So if the patient has been on opioids for some time, they're doing well, they're meeting their functional goals, and they're above 120, that's okay, as long as it's documented. Well, how can a physician become exempt from not having to seek a consultation once their patients get to the 120 milligram or above dose? Well, obviously, if the physician is a pain specialist, and if in the last 2 years you have completed 12 hours of continuing medical education on chronic pain management, and at least 2 of those hours are dedicated to long-acting opioids and methadone. Now, can you double dip into that 4-hour CME requirement for long-acting, and the 12 hours are required to become an exempt physician? Yes. And again, the 4 hours for the long-acting opioids is once in a lifetime. So if you're a physician who is working in a large group, and there is someone in your group who does not meet the definition of a pain specialist, but you trust that person, the person does good work when you refer, you can still use that referral source as long as you're exempt. And that means in the last 2 years, you yourself have completed 12 hours of CME on chronic pain management, 2 of those hours related to long-acting opioids. You're an exempt physician if you're working in a multidisciplinary chronic pain center or an academic research facility, or you've had a minimum of 3 years of clinical experience, and at least 30% of the time, your current practice is in pain management. So finally, what is the definition of a pain management specialist? And trust me, we left the best for last. If you're board eligible or certified by the ABMS approved board or the American Osteopathic Association, if you have a subspecialty certificate in pain medicine by ABMS approved board, or a certificate of added qualifications in pain management by the AOA, or if you've had a minimum of 3 years experience in chronic pain management and you're credentialed in some way, and you've completed at least 18 hours of CME in pain management during the last 2 years, and 30% of your current practice is in the direct provision of pain management care. So the definition of a pain specialist is a little bit complicated, but we felt like these definitions were inclusive of the physicians practicing in our state. So in summary, these pain rules are for the management of chronic non-cancer pain. The rules, as required by legislation, were to be adopted by June 30th, and we have met that deadline. For the Medical Commission, the rules require implementation 6 months from now, by January 2nd, actually 2012. So we have a 6-month period to disseminate the information, to get out the education. Now, I think there are about 200 of you here today. Where are the other 27,000 licensees in our state? I'm curious. So what's next? We are already monitoring the response to the rule. I hope you'll walk out of here today feeling much more comfortable about the rule, hearing the facts. There is so much rumor and misinformation about that. Literally every question I have fielded about the rules, the person asking the question had inadequate information or really had not read the rules. And the rules are complicated, particularly when you look at the definition of a pain management specialist. So we are monitoring the response to the rule, and we are evaluating every question that comes in. I was emailing to a physician in Eastern Washington yesterday questions about methadone and some discrepancies with the medical director guidelines. So there's going to be ongoing monitoring. And all along we've talked about, are we going to get this right the first time? You know, this has never been done before, and we're doing it in a year. So we knew that there at some point would likely be some modifications based on the response, and we would probably do things a little bit differently today. But we have already received a formal petition from the WSMA and from the Association of Family Practitioners to amend the rule. And we will be considering this petition at our next meeting and deciding what to do for that. I know that there's going to be some amendments along the way, so that I'm sure that that process is ahead of us. And that process then starts back at the beginning of the rulemaking process and goes through public hearings, you know, opportunity for public comment, and the entire process. So those are our websites. Stay tuned. There is certainly more to come. And thank you for being here this morning.